Here we will be dwelling on the adrenergic blockers, and we will discuss it depending on the receptor subtype. So first, we will be targeting the alpha blockers and then eventually the beta blockers. Now, remember, we are now dealing with blockers. We are dealing with antagonists. So whatever effect we see here, we need to reverse that to interpret how the drugs work. So again, we start with the alpha blockers. In terms of how many references divide them, we could actually call them first alpha non-selective or alpha 1 selective blockers. So alpha non-selective means that it doesn't really distinguish the two alpha 1 and 2 receptor subtypes. I mean, they are selective in the way that they still don't target beta receptors, but it's still not so selective that it doesn't really distinguish these guys. On the other hand, of course, if you say alpha 1 blocker, then that means the full committal is only to this specific area. And here are the examples of those. For the alpha non-selective ones, we only have two popular examples. Luckily, they both start with the letter P. So there's that. We have phentolamine and phenoxybenzamine. Whereas for the alpha 1 blockers, they're more numerous. There are usually 4 to 5 classic examples, and I have 4 here: prazosin, doxazosine, tazosine, tamsulosin. So usually they have the suffix zosin. Tamsulosin is the only one which is kind of different because it's leucine, but it's quite close. And the chemical structure common to them is quinazoline. I just thought of writing this because when I was in the agonists, I did mention the word imidazoline and guanidine. So just for consistency's sake. And now, for the two here, unfortunately, they don't have a common suffix, but it's a good thing because there are only 2 of the popular ones. Now, let me first start with the alpha non-selective blockers. First, in references, so I actually could not say this anymore, but it's on my brain right now, so I'm still gonna say it. The only difference between phentolamine and phenoxybenzamine is their reversibility, because this one is a reversible alpha non-selective blocker. This one is said to be an irreversible one. But despite that difference, the way they are used is exactly the same. They are both used to decrease blood pressure. Why? Because remember, alpha receptors affect the blood vessels. Alpha 1 causes vasoconstriction, alpha 2 causes vasodilation. But take note that this is presynaptic. If you actually activate the postsynaptic alpha 2 receptors, which is what normally happens in the body also, it's also constriction. So it's kind of the more dominant phenomenon when you combine these two. So of course, since we're talking about blockers, you get the reverse of that, then you get vasodilation. And we know vasodilation reduces blood pressure. However, it's not actually the case that these are maintenance hypertensive medications. In fact, the only time that you use these two drugs for is for reduction in blood pressure before you do surgical operation on a tumor called pheochromocytoma. Pheochromocytoma is a tumor that releases a lot of norepinephrine. And since norepinephrine is going to activate all of these guys, then of course you expect a rise in the BP. Basically, surgical procedures are not going to be good. They're going to get ugly if you treat a patient with super, super high BP. And since these guys really directly inhibit norepinephrine, especially on these receptors, they are wise to be given before you do the surgical removal. Okay? As for the alpha 1 blockers, these are actually the more routine antihypertensives because the way they work by simply blocking the alpha 1 receptors is a straightforward way to lower down the blood pressure. And that's what all of these are used for. But other than that, there is also another use. So this is just one of those. Another use is for a condition called BPH, which is benign prostatic hyperplasia, wherein the prostate gland, so we're referring to males, becomes very large such that it now blocks the path of the urine through the ureter. So people, usually we're talking about middle-aged men with BPH, find it very difficult to urinate. And even if they do, it's very painful because there's some kind of, blockage in the way. And one thing that's not so much talked about alpha 1 to the point that I didn't even write it anymore here is that there are also alpha-1 receptors in the prostate that cause it to contract and therefore cause it to block the way. So if you block this effect, then the contraction will not happen in the first place. The prostate will not get in the way. Urinating is easier to do. Okay? So that is the mechanism behind alpha-1 blockers, like I think tamsulosin is one of them. And alfuzosin, let me add the other zosin, making them BPH medications. Now, let's talk about the adverse or side effects of these guys. Well, from top to bottom, we acknowledge that all of them cause vasodilation. And therefore, the result is lowering of the blood pressure. But of course, again, the classic, the dose makes the poison quote reminds us that, well, if your blood pressure goes lower than the standard, then we have hypotension. And hypotension is almost just as dangerous as hypertension. You get dizzy and you get weak. So you cannot give too much of these guys. Additionally, there's also an effect called reflex tachycardia, wherein, ironically, tachycardia will increase blood pressure. But why? This is the body's way of responding to this. Because the body normally just does its thing. And if there's a medication that is all of a sudden reducing the blood pressure, the body is shocked. It's like, what's going on? Why are you doing that? So take this in consideration. Remember how the alpha blockers don't affect the beta receptors. So in other words, they don't have a hold on the heart. So the body has now full control over the heart, telling it, hey heart, can you increase your heart rate for me? Because I need to cancel out what this is doing. And so that's why we call it reflex tachycardia. It's the body's expected response to your alpha blockers. So at the same time that you are taking, for example, your prazosin or your terazosin, your body is expected to respond or to rebut by doing this. Okay? And one more thing, orthostatic or postural hypotension. So actually, I already mentioned this, but this is a special one because this is what happens when you, for example, change your posture quickly, like you're sitting down for 1 hour and you stand up very quickly. You feel dizzy because your blood pressure is currently low, that your blood from the head temporarily becomes short. It drops down due to gravity. And that's why people having this feel like everything around them became white for a while. Okay? And this can prove to be annoying at times until the body eventually adapts to that. In fact, this effect is so evident in prazosin that this one has been given the term first dose phenomenon. People who are taking prazosin for the first time experience an immense level of orthostatic hypotension, much greater than the rest, which is also a reason why prazosin is not anymore a first-line medication. This can prove to be quite annoying at times. Okay? So that's it for our alpha blockers. Now let's go to the beta blockers. Of course, we have two receptors, beta 1 and 2. And just like a while ago, we have the non-selective and the selective blockers. Beta non-selective is still selective because it doesn't at least target any alpha, but it's still termed like this because it does not distinguish between 1 and 2. But beta 1 obviously means it only cares about this guy and minimal effects on this one. And what are examples? Actually, across the board, it will be very helpful to see that the suffix, not all of them, but majority of them have the suffix O, lol. Okay? And this can be quite dangerous also for the beginner because there's actually no way for you to distinguish a non-selective and a beta 1 selective blocker based on the suffix. Also, for people who are knowledgeable with beta blockers, they know that this list is far from complete. And there are even some beta blockers with specific adverse effects or specific uses. I cannot list down all of them in this video. So I will just be going with generalities. Please be gentle with this one. All right. And here we have 4 of the popular non-selective blockers, of which propranolol should be the most popular because it's one of the earliest and one of the most investigated drugs of all the guys here. And for the beta 1 blockers, These ones are very popular maintenance medications. I'll talk more about that. So now what's about their use? Or what is their use? Well, again, whether it's beta non-selective, targeting these two, or beta 1 selective, they all target the same thing, beta 1, which is, of course, located in the heart. So it is safe to say that all of them perform effect on the heart. Particularly what? Reversing of this effect. So I'm talking about reduced heart rate. It does reduce contractility also, but history tells us not so much. Okay? And therefore, if you reduce the heart rate, you also reduce the blood pressure. So in other words, these are some of the classic anti-hypertensive medications, just like our alpha-1 blockers a while ago. Okay? Now, you may ask, what is now the necessity of having beta-1 selective blockers when beta non-selective blockers just do the same thing and are used for the same purpose? And here lies the problem of blocking beta-2. We know that beta non-selective blockers block beta-2, right? But what does that mean? You are reversing bronchodilation. What does that mean? Bronchoconstriction. Is this good for people? Generally not, because it will cause them to have more difficulty breathing. You know what? People with asthma, therefore, get triggered with these. So this is a disadvantage for people with asthma. And since I already mentioned an adverse effect, let me already write that down. Asthma, or at least the triggering of that. And thus, scientists were like, all right, blocking both may not be a good idea, specifically here. Why not make those that only focus on this receptor? Thus were born these guys. And since they are only targeting beta 1, which is in the heart, we can also call beta 1 blockers as cardioselective beta blockers. By not targeting beta 2, you are at least minimizing the asthma occurrence. And therefore, these are safer for those guys. Okay? Now, what else can we use these beta blockers for? Remember, the way they work is by reducing heart rate. Some arrhythmias are excessively high heart rates. So we can also use beta blockers as anti-arrhythmics. However, one of the things my teacher taught us is usually those that treat arrhythmia also cause arrhythmia. So, for the case of beta blockers, that's excessive bradycardia. All right. And one more thing. Since beta blockers are continuously slowing down the heart for as long as the person is taking them, there have been documented cases wherein a patient stops taking the beta blockers immediately, then their heart starts racing to no end, tachycardia. And the adjective that we're going to use here is the word rebound, because this only happened after the beta blockers have left the body, once the patient stopped taking them. That's not the same as reflex. A while ago, reflex happens at the same time the drug is being taken. Rebound happens only after stopping or discontinuing the drug. I noticed that's something that students think are interchangeable, but they're not. So basically, beta blockers are really a lot about the heart. Again, I did mention that there are some of these, especially propranolol, like can be used for migraine, even used for thyroid problems, but I would not want to make that the focus of the discussion. One more thing. Do you know that we actually have a dual alpha-beta blocker? We have two of them, Carvedilol and Labetalol. CL, luckily so far they are the only two popular of these class, so two, hopefully easier to memorize. Carvedilol is more of a maintenance medication for patients with heart failure. And Labetalol, and I think Labetalol will really exude why you even want this to happen, is for emergency cases, emergency hypertension. Okay. Now, remember, what was the problem a while ago of blocking only alpha? There was reflex tachy, right? And you can't do anything about it because being only an alpha blocker means you have no hold over the heart. Now, since we have a dual blocker, you can also block the beta receptors, and therefore the tachycardia will be canceled out. That is why dual alpha beta blockers have the advantage of lowering blood pressure and preventing tachycardia as a response. Oh, since I said that, one last thing. Do you know that patients with diabetes who have hypoglycemia, usually the manifestation is tachycardia? So this is an emergency sign. Oh, the diabetic patient is having a very fast heartbeat. It's an emergency case. But if a patient with diabetes with this is taking a beta blocker, the tachycardia is canceled. And that's why we have a term called masking. You don't know the patient is already in a life or death situation because the way to know, which is fast heartbeats, is being masked. And that's why in cases, it's not advised to give beta blockers as maintenance medications for diabetes patients. And that concludes our alpha and beta blockers.